Okay, thank you very much for having me here. Today I would like to talk about is there any hope left in the intraoperative suprachoroidal hemorrhage. Okay, so, speaking about the hope, I can guarantee that there is no very terrifying movies or video in this slide. Okay, so I have no financial disclosure. So, speaking about suprachoroidal hemorrhage, everyone knows that it is, even though it's uncommon, it has a highly devastating intraoperative complication that can cause the permanent visual loss. And it is actually the bleeding from the choroidal vessel into the suprachoroidal space can cause it by the sudden compression and decompression event that it can cause a rip in the choroidal vessel and leaks of the blood into the suprachoroidal space, which is the potential space that can expand that can expand and cause the damage. And it's caused by the impeding vortex venous outflow from the retrobulbar anesthetic injection or retrobulbar hemorrhage and any excessive pressure in the back of the eye. And the final visual acuity is also very unpredictable from very good visual acuity to the NPL, depending on the severity of the hemorrhage or the apposition of the retina or incarceration of any other of the retinal tissue. So we all know that the incidence vary depend on the procedure. In the PPV, it accounts for about 0.2 to 2%. It is a little bit higher from the phaco emulsification, and it's much lower in the in the large wound cataract surgery such as ICCE or ECCE, which is accounted for about 2 to 3%. So, but 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 we, but the risk factor that we are looking for is the preoperative and intraoperative. We have to look into if the patient has advanced age, atherosclerotic risk, any glaucoma or myopia, aphakic and pseudophakic, and especially the patient who has the previous suprachoroidal hemorrhage in the last fellow eyes. And during the operation, we have to check if there any sudden drop in the IOP or any uncontrolled systemic hypotension. It can lead to suprachoroidal hemorrhage. So the severity of the suprachoroidal hemorrhage can be classified by into three stages. The first one is the limited suprachoroidal hemorrhage. It is defined by the limited extension, maybe around 1 to 2 quadrants. At this stage, the suprachoroidal hemorrhage can be spontaneously resolved within just 1 or 2 months after we close the wound. But if we cannot control it, it can progress into the more massive suprachoroidal hemorrhage. It is defined by the kissing of the hemorrhagic CD and leads to apposition of the retinal surface and cause traction or rheumatogenic retinal detachment in the futures. And at this stage, the patient may need a surgical drainage. And if we still cannot control it, it can become an expulsive suprachoroidal hemorrhage, which can cause the extrusion of the intraocular contents outside of the eye. And at this stage, we have to admit that we lose the war. So I would like to highlight the importance of the limited suprachoroidal hemorrhage because, as you can see, that in this patient, it is just a regular RRD, but during the operation, this patient has a hemorrhagic CD, and so the surgeon decided to put silicone oil, and after 1 day, the operation, you can see that the hemorrhagic CD is still there at the 1 to 5 o'clock, but after 1 month, the all of the hemorrhagic CD completely gone, and after remove the silicone oil, it's like nothing ever happened, just only the laser scar from the vitrectomy. It is another cases that highlight the importance of the of the limited suprachoroidal hemorrhage. And you can see during the operation, hemorrhagic CD occurred during the silicone oil filling. As after 1 day, the hemorrhagic CD is still there, like half of entire eyes, and just 1 month, it's completely gone, just the silicone oil. And after remove the silicone oil, is look pretty promising. This confirms that if you can control hemorrhage, it can bring the good result. So this highlights the importance of early recognition and timely management to prevent limited suprachoroidal hemorrhage to turn into the massive one. And so if we can control it fast, we can save the eye. And if we already have the massive suprachoroidal hemorrhage occur, the thing that we can do is we can just control the damage before it's turned into the expulsive one. So there are signs of suprachoroidal hemorrhage that warn us, such as if the patient has the excruciating pain during the operation, you need to be alert of the suprachoroidal hemorrhage and any other signs of the change during the surgery, such as sudden AC shallowing or any red reflex loss or the black shadow progressing in the back of the eye or the eye become tense. That means that the pressure of the eye increase. You have to be mindful during the fluid air exchange because it can be the infusion can be slip very easily as Dr. Andrew show us. And during the silicone eye extraction, we can cause the abrupt change of the IOP during this step, and also the oil injection as well. And other warning signs are the prolapse of the iris that cannot get back, or any lens, intraocular lens that just jump up into the anterior chamber. So the thing that we can do is not to panic at first. Okay, the thing is we need to immediate tamponade all wounds. We need to rapid wound closure. If the nurse didn't bring out the needle or the stitches, you just use your finger to create the direct digital pressure, or you can just inject the high viscosity viscoelastic to tamponade the vitreous. And you need to control 3 P's. The first is BP, second one is IOP, and the third one is pain control. So, but you need to control it fast. So the best route is to give the medicine to be the IV, and you can put the head of the patient a little bit higher in the reverse tendilambar position to decrease the ocular blood flow, and you need to try to have a short communication with our patient to make calm and comfort the patients. And during vitrectomy, as Andrew showed us, you need to check the infusion first. Otherwise, you can create more suprachoroidal hemorrhage, because sometimes the infusion can bury underneath the suprachoroidal hemorrhage. So it is better to check the infusion first before you turn on the infusion or attach, or you can, if it is already off, you can just quickly attach the infusion tube and check if it is inside the vitreous cavity or not. And if it is not, you need to create the infusion the other side that is in the safer place, or put it in the hand port. And you can use the longer infusion torque cannula to get it past the suprachoroidal into the vitreous cavity. And you can use the silicone oil or heavy liquid to create the tamponade before the blood is getting more into the suprachoroidal space, and seal all the incision to create the tamponade effect after the surgery. And for the post-op management, you can use the pain controller or corticosteroid to release the inflammation. And of course, we need to control the IOP. Please avoid using the aspirin or any NSAIDs, which can cause more bleeding into the suprachoroidal space. And you need to closely monitor and modify other risk factors such as any BP or coagulopathy. And there is some role of surgical drainage, which is the posterior sclerotomy and fibrinolytic agent in this case as well. So speaking about the surgical drainage, the operation that we need to do is this posterior sclerotomy, which can drain out the blood and separate appositional CD, and to prevent secondary TRD or RRD in the future. From the study, which is the systematic review study, shows that they in the group that have the drainage only can have the mean BCVA improvement more than combined PPV with drainage. So just that would be enough. And ideal timing for drainage would be around 10 to 14 days after the clot is lysis. You can use the serial B scan to check whether it is already lysis or not. You can observe the hypoechogenicity turning to the hypocoagenicity of the mass after you follow up. And these are the indications for the surgical drainage, such as severe pain, uncontrolled IOP, any persistent flat AC, kissing CD, RD, or any serious organ involvement, such as macular involvement or the incarceration of intraocular content into the surgical wound. And this study also showed that the final BCVA also better in the non-appositional suprachoroidal hemorrhage and the limited one, which is accounting for around 1 to 2 quadrants. So this highlights the importance of early recognition and the benefit of timely management before it can progress into the massive form. So this is the video of of the drainage from Dr. Achala. Actually, we try to drain the suprachoroidal fluid from the nasal side, and at first we put the torca, which is a non-valve. I think this non-valve would be the better option, because if you put a valve, the blood we cannot pass to it very easily, and we can just put the infusion pressure into the anterior part and use the torca to create the sclerotomy. The ideal site to create is maybe around 5 to 6 millimeters behind the limbus. As you can see, sometimes we can use the MVR blade to create the larger wound to bring the blood out. And right now we have some study reporting the role of fibrinolytic agents to accelerate the clot lysis and allow earlier drainage of the suprachoroidal hemorrhage, and it also showed the promising results. The recent study on the RTPA, which is the recombinant RTPA, and many others inject it into the suprachoroidal space around 5 millimeters from the limbus, and dosing can be ranging around 10 micrograms to 100 micrograms, and the role of urokinase type plasminogen activators in the sublingual injection. But these studies are only few studies, so we need larger study at RCT to prove the benefit of this fibrinolytic agent. So this is, I would like to share this case. This case is in the front of this slide. This is a 64 years old female with a lot of underlying disease which is related to atherosclerotic risk, such as diabetes, hypertension, and chronic kidney disease in stage 5. Her EGFR was 13 and was subjected to dialysis. And she was diagnosed with the ankle closure of the left eye, and was initially planned for the phaco about 4 weeks ago. But unfortunately, during the operation, BP comes up and patient was really painful, and AC become shallowing. So at the time, the surgeon think that they may be the fluid misdirection, so they did the vitreous tapping. But it turns out that they have the bleeding coming from the ciliary sulcus, and the relief was turning dark. So that's why that at the time the surgeon think that it should maybe the suprachoroidal hemorrhage. So they managed very quickly with the IV mannitol, IV sedative, and nicardipine, and close the wound very rapidly. Ultrasound confirmed that there was a vitreous hemorrhage and suprachoroidal hemorrhage at the temporal site, which is luckily spontaneously resolved within 2 weeks. So this at the time I plan to do the vitrectomy with the fragmentome. As you can see, the lens is still there, and do the scalar fixation under the GA to not create more pain to this patient, and put the IV cryoprecipitate in the pre-op. As you can see the video here. Sometimes it may look great because the suprachoroidal hemorrhage is already gone. But after I dig in, can I move the video? I'm not sure. Okay, so let's see. So first I try to rotate, to bring back the vitreous that already trapped into the wound, and put some viscoelastic, and then push the lens back, and let's see if there is any incarceration of the vitreous into the wound, and check the port if it is into the vitreous cavity or not. And luckily it already into the vitreous cavity, so I do the vitrectomy. As you can see, there's a lot of vitreous hemorrhage, and lens is still there. So I push the lens back and clear off the vitreous hemorrhage. Okay. Now I try to create more visualization, and I see that there is some traction at the periphery caused by the apposition of the retina here. So I try to release of the traction from the vitreous and from the retina as well, but I don't want to create more bags, so I just leave it there and clear off of the vitreous, and I clear off the lens, And after I clear the lens, it's just right now. It's just retina and and me right now. So as you can see, there's some traction over here and subretinal hemorrhage. So and I think that it is not quite safe to put the fluid action because it's gonna push the fluid from the periphery back to the macula, which is still on here. So I do the laser barricade over the 360 and just leave the water, just close it with the balance of, okay. And here's the case. So after 1 month, the laser is become more mature, and the traction at the periphery was going down. So I think that it is quite safe for this patient, and her macula is still on. And after 2 months of follow-up, I do the refraction. The visual acuity was 20 over 80. So and the retina is going down, and all the subretinal hemorrhage is quite almost completely resolved. So I think that it is quite safe for the patient to do the scalar fixation. But unfortunately, after one month, 1 day before the scalar fixation, there is some break open at the traction here. But luckily, with that I did the laser, the fluid cannot creeping inside of the macula, but creeping just from the inferior part. So that's why I abandoned this operation and changed into barcode 240 and 280 at the temporal side and put oil back into the eye. And here is the visual acuity. Here's the eye. After 2 weeks, you can see I want I don't want to create more breaks, so that's why I put the barcode to support all of the traction, and all the traction were sitting on the barcode very nicely, and I pushing the brake back. So in conclusion, it is important to identify the high-risk patient early because we don't want to actually have the suprachoroidal hemorrhage, and it is very important to recognize and respond promptly because timely diagnosis and management are crucial to optimize the outcome. And please do not hesitate to escalate quickly, and do not and if you have any suspicious sign of suprachoroidal, just close the wound or call the senior and ask for any surgical support when needed. When needed, and and as the topic, is there any hope? Actually, the hope is not the patient or disease. It is us. Us, we are the hope for the patient. So remain hopeful even in the severe case. Timely intervention can preserve structural and functional outcome of the eye. Okay, thank you.
Thank you, Dr. Peranut. Very nice presentation. You highlighted all the importance and the timings, and it's one of the gravest complications which no one wants to have. So, we have any questions from the audience or the panel?
Two questions.
Please.
Excellent presentation, sir. Two very basic questions. What is the ideal site of external drainage for massive suprachoroidal hemorrhages post-operative, and how do you determine it?
Okay.
What is the site of the drainage? Is there any role of B-scan or any other thing that you use?
Okay.
And second would be, can you answer the first question first?
Okay, so normally I would use a non-wounded Tokai cannula, and I just put it in like around 15 angle to be slightly parallel to the sclera to ensure that it is not going to go into the vitreous cavity. So if I begin it at this stage and it doesn't come out, I will put it out and do a sclerotomy. So the largest sclerotomy I have done is around 3 millimeters. Mm-hmm.
So any particular quadrant you prefer, or any quadrant would work for you?
It's just the highest side of the suprachoroidal hemorrhage,
so
and
I think B-scan
yes,
is going to be the primary indicator, like that's the primary investigation that you rely on.
yes, it's very helpful.
On that, then what would be the ideal time of drainage that you would prefer in massive suprachoroidal post-operative hemorrhages?
But normally I would do about 2 weeks. I would wait for the clot lysis, even though from the ultrasound shows that it become the hypoechogenicity. I still wait for 2 weeks in order to let the clot to lysis completely.
And as you mentioned in your talk, there were some cases in which you extracted the hemorrhage 3 to 5 days after it happened. So when was that? Was it completely dependent on the use of TPA, or there were some other factors which were responsible for you to decide that particular?
No. It depends on what type of suprachoroidal hemorrhage. We also divided into two types: intraoperative and delay. In delay, we usually seen it in the post-glaucoma surgery. At that point, you can just drain it just one day after this, or maybe 48 hours after the surgery, because you need to close over the like leaking wound of the glaucoma. You can just drain it at that point. But if it is like from the cataract or vitrectomy, I would just wait for for 2 weeks. But I have to admit that I don't have any experience for using any phlebotomic agent at that point. Yeah.